Can you see my screen, guys?
Yes.
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 All right, let's start with, this is actually kind of out of place because this should be discussed together with cancer, but I forgot why I put it in module 3. Anyway, there must be a reason. Okay, let's discuss bone marrow aspiration and biopsy. Bone marrow aspiration is a diagnostic tool, a diagnostic procedure to help determine the cause of signs and symptoms, particularly anemia. Most autoimmune diseases will, autoimmune disease patients will undergo bone marrow biopsy just to rule out other causes. It could be cancer, or they just want to determine whether or not it can be cured with bone marrow transplant. So in order to, before we can do bone marrow transplant, we have to, of course, get a bone marrow from a donor. So you will have two patients here. For one, for if it's used for diagnostic purposes, of course, your patient will only be the patient. If you're having to do a bone marrow aspiration as part of the whole process of bone marrow transplant, then you'll have two patients, obviously. Again, these are the most common diseases for which we will expect a bone marrow aspiration and biopsy. Before we can do a bone marrow transplant, though, obviously the patient, if the patient has any of these conditions here, tumors or leukemia, if we transplant some other person's bone marrow into the patient, it will just be overrun by the cancerous cells. So before the procedure, the patient will have to undergo extensive chemo or radiation before they can do the procedure. So let's begin with harvesting, and which is done by aspiration, and then for purposes of biopsy. Here is how you prepare the patient for the test. Most common sites for aspiration are the following. For the adult, it's usually the posterior superior iliac crest. That's around the hip area. Sometimes, which is not very often used, are the sternum and as well as the anterior posterior iliac crest. You can also get it from the spine, from a rib or the tibia, but most common is the hip. It's extremely painful. We're talking about a 8-inch needle, about 18 gauge or larger. Could be as 14, 16, or an 18. And of course, if you imagine, if you have to stick that into the bone, that means you can't just insert it straight. Plus, you can imagine all the tissues you'll have to go through in order to reach the bone. Are you guys with me?
Yes, Professor.
Oh, okay.
Yes,
It's
Professor,
so
we are
silent.
there.
Just wondering because could be talking to nobody here. So when the needle, it will have to be done in a twisting motion. So you'll have to core and burrow in the put the needle by burrowing it into the bone. So that causes a lot of pressure, a lot of pain. Yes, we will use anesthetics, local anesthetics for this procedure, but the patient will continue to feel pressure. The pressure will be felt on insertion and also during the actual aspiration of the marrow. So you'll feel the pulling pain, there's mild suction. Um, Overall, I mean, it's an uncomfortable procedure, okay, both for the donor and the patient. It's not very long, thank God. It's only 5 to 10 minutes. Bleeding will be a problem for a possible complication for both. Again, in considering how deep this needle is inserted and how many tissues are involved, so a lot of trauma. Um, so there will have to be a long pressure application of pressure on the aspiration site. And here are your responsibilities um, on caring for the patient. Now, after the procedure, I'm not testing this one because we're not doctors. We're not going to interpret the results. Here's a illustration of how it's done. So this is how you position the patient. So imagine coring the needle into that part. See how long this needle is? And here are your responsibilities after the test. I already said applying direct pressure for about 5 to 10 minutes. It usually is longer than 10 minutes because it will take a while before the bleeding stops. And then we just cover the site with a dry, sterile dressing. It will be dry gauze, which will be secured by a clear tegaderm. If there is bleeding, which is again likely, if it continues over 24 hours, then make sure you notify your physician. We're missing somebody else who's not here. Israel, okay. Any questions about the procedure? This is pretty much it. None? Okay, let's continue.
Professor, did you say that this is a procedure that we have to assist with or that we have to do?
No, we are only assisting. The physician performs the procedure.
Okay.
But thank you.
Professor, and you said 33.8 is not testable?
This table right here? No, because we're not interpreting. Unless you want to, I mean, you're welcome to do that.
No.
Professor, is this usually done at the bedside?
Yes, it's only done at the bedside. But the transplant procedure, though, will be done in the OR.
And do patients usually get some sort of analgesics beforehand?
Yes, I mentioned earlier local anesthetic. All right, let's talk about transplantation. There are 3 types of rejection because our concern here with kidney transplantation or any other solid organ transplantation is rejection. Now, let me discuss the concept because it's not mentioned in your textbook. You can see the whiteboard, right?
Yes.
Okay. So on the surface of our cells, let's say this is a cell. So we have protein IDs on the surface. It's unique for each person. You may have an identical HI. We call this human leukocyte antigens. So again, it's a protein found on the surface of every cell, every red blood cell, whatever cell or tissue it is in the body. So all our cells have a specific, unique human leukocyte antigen. This allows our cell to recognize itself from non-self. Right? So it enables us to recognize whether a cell that has entered the body is foreign or friend. So as the immune system cells run around the bloodstream, they bump into a virus or bacteria, for instance. It will therefore cause a mismatch. So when they bump into these foreign cells, they don't recognize it, and they will trigger the immune response, stimulate production of lymphocytes, um, and then your immune system is activated. So that's how it works. Now, in organ transplants, so a patient lost a kidney, a lung, a heart, for instance. So organs fail, and then one of the considered treatments is transplantation. After a painstaking procedure of finding a match, we do that again by matching your HLAs. Of course, we will never see a perfect match. Maybe if you have an identical twin. Since most of us don't, it would be extremely hard to find a match. But once we do, it's only close enough. So once we find a close enough match, so we do further testing, and again, our goal here is, since the HLAs are not a perfect match, we will call the recipient here for purposes of discussion. The recipient here will be called the host, and then the donor, we will call it the graft. Okay, the donor, I mean, we're referring to the solid organ here. A common example of a transplant is a blood transfusion. So in blood transfusion, we are transferring tissues from and cells from one donor to the recipient, right? It's very common. We do that all the time. It's not as simple as a blood transfusion, though, wherein you just do a typing and cross-matching, and then you do the transfusion. Here in bigger organs, specifically either bone marrow, or if we're transferring a solid organ, such as a kidney, a liver, a lung, or a heart, etc., it will require more extensive testing because these are larger organs we're talking about. So because again the HLAs are not a perfect match, we will have to, in order for the graft to survive inside the host, we will have to suppress the immune system of the host. And for a short while before surgery, we will do the same for the donor. We will have to immunosuppress the donor as well, only for a short period, just until we surgically remove the graft, and then there will be off the immunosuppression. Our goal here is to keep the number and activity of your immune system, particularly lymphocytes, so that they don't do their job too well, because again, we're dealing with a foreign HLA here. So the minute it enters the body, if we have immune system, if we have competent immune system here, of course, what will they do to the graft? What will the host immune cells do to the graft when you put it in there? What will they automatically do?
Attack it.
Yeah, they will kill it. And that won't change. No matter how long this graft stays in that host, that's what's going to happen. Because it's a foreign object. It will never become part of yourself because it looks different. It has a different HLA. You can't change it. So of course it will remain a foreign body, and therefore will remain a target for your immune system. So again, our goal here, in order for this graft to survive, is really to suppress the immune system to a certain extent that it will prevent it from killing it. However, since again this is a foreign HLA we're talking about, there will be rejection. There are three types of rejection. One is acute, we have hyperacute, then we have chronic rejection. So we will answer three things here. So hyperacute, acute, and chronic. First is when. When will it happen? For acute, this usually happens within 48 hours. Most cases occur, no, sorry, I'm talking about hyperacute. Sorry, erase that. All right, I'll begin with hyperacute first, because this is the rarest, so we'll get it out of the way. So within 48 hours, most cases, as I was saying, occur right there on the operating table. So as soon as blood flows into this graft, as soon as they attach anastomose the vessels from the donor graft to the host vessels, and then you unclamp the arteries and veins, and then blood starts to flow, right? So the reaction, what happens here is, let's put another column here. What happens? What happens in hyperacute rejection is, although we did all our due diligence in testing, matching, and then doing the immunosuppression therapy before, during, and after the surgical transplant procedure, there will still be something left there. What happens is, and it is very rare, this is extremely rare, just a freak event that this causes a antigen antibody reaction wherein it triggers clotting. There is widespread clotting that happens here. So imagine if thousands, millions of clots form in the vessel inside the graft as a result of this antigen antibody reaction. What will happen to the vessels? And therefore, what will happen to blood flow or perfusion into the graft? If you have hundreds of thousands of clots that will form in every capillary, every artery, and every vein, what will happen to the graft?
Infarction.
Which will do what to the graft?
Oh, the graft would die, or I guess.
Okay, there will be ischemia, and then of course necrosis, and then death of the graft. This occurs within seconds, right? But it can occur at any time within 48 hours of the transplant procedure. So again, it's a very sad event. Next question is, what can we do? Or treatment? Nothing. All you do, the organ is gone. The graft is gone. So you take it back out, throw it on the grill. I don't care what you do with it, but it's gone. Right? It's no good. And we just break the sad news to the patient. No, it didn't work. Sorry. Extremely rare. We did everything we can. This happens rarely, but it can happen. Any question on the hyperacute? All right, let's go now to the acute rejection. Acute occurs within 1 week to few months and sporadically. Meaning it's not a one-time event. Sorry, I should really write better. Okay, 1 week to few months and sporadically. Meaning it's not a one-time occurrence. It can occur again and again. Let's just take out one episode, for instance. Let's say it occurs a week after. What happens is there's two things that will happen here. One is vasculitis, or inflammation of the vessels inside the graft. It's different from hyperacute. In hyperacute, you have clotting because of an antigen-antibody reaction. Here, there's inflammation of the vessels inside the graft, causing it, of course, what will happen if it's inflamed? What will happen to the wall of the vessel? Will it thicken, or when it will widen, right? So what will happen to the lumen of the vessel? If the wall of the vessel thickens or gets inflamed, what will happen to the size of the vessel, the lumen? It will go narrow. So therefore, if it's narrow, what will happen to blood flow through it?
There's going to be less blood flow through it.
Less blood flow, because now the vessels are narrow because of the vasculitis. The second mechanism involved is a cytotoxic in nature, meaning although we gave this patient everyday immunosuppressive drugs, right? Every single day, no without fail. The saying goes that what doesn't kill you makes you stronger, correct? And nature finds a way. So somehow, some way, the immune system of the host found a way to get around the immunosuppression. Meaning, no matter how hard you held it back, it somehow found a way to fight back. Because it will, again, make sure its main mission is it's already triggered. It's already activated. They know there's a foreign object there. So they will plan out some way. We have to kill that. Right? They have no choice. It's a foreign object. That's their job. That's their one job, is to kill any foreign invaders. So somehow, some way, the immune system found a way and then tried to kill it. So again, vasculitis and cytotoxic activity, meaning killer cell activity. Okay, so killer which is, this is the natural event, okay? Of course, they have to kill a foreign object, but in this instance, though, we don't want them to do that because we need this graft, right? We need that kidney, we need that liver. So what can be done about this? Fine, we can do drug management here. So what the doctor will do is adjust the dosing of the medication, maybe add more medication. Usually they'll add a steroid, put the patient on high dose steroid for a few weeks or months until the symptoms of rejection disappear, and then they'll stop, and then they'll be back to their usual drug management. The only thing is this is not, again, a one-time occurrence. This will happen again. So how many times? We don't know. But we know we have to watch out for acute rejection. It will keep happening again and again and again. Any question on acute rejection? All right, so last one is chronic. This one obviously is months to years. Now, unlike acute rejection, wherein it happens within a week or after a few months, and the events happen so fast that you will see the signs and symptoms clearly right there as it happens. Not so in chronic rejection. The mechanism involved here is chronic inflammation and scarring. So little by little, the organ parts of the graft gets inflamed, and you know how inflammation goes. Inflammation will cause swelling, edema, and then necrosis, but little bits at a time, a few cells at a time. And after you have inflammation, similar to vasculitis, but this one again occurs so slowly. So little by little, parts of the graft die, become scar tissue. Again, another part dies, becomes scar tissue. But the events again happen so slow and over a long period of time that you don't notice it. So technically, if you look at it, it's like this organ is failing all over again. So just like what happened before, wherein before the patient had a transplant, so the organ died for some reason, however fast that occurred, but this one definitely occurs really, really slow over a long period of time. Because the events happen that slow and we don't notice it, there is really no treatment. We can delay progression. How do we delay? Drug management. But it will not stop the inevitable failure of the graft again. It will fail one day. All right, all we can do is just delay it by adjusting the dose, adding more medications like steroids, but it will not stop the events. Once it started, it can't be stopped. Any questions on acute, hyperacute, acute, and chronic rejection?
I have a question, Professor.
Go
So
ahead.
for all of these, I mean, it's all being rejected. So like, what's like another treatment that you can give them aside from this that like would help them?
What do you mean? To
Or
treat?
is this like the only thing that you can do for them? Is the bone marrow
I mean,
transplant?
if you have better ideas, we'd like to hear it, because again, we're replacing the patient's organ with another organ coming from another person who does not have the same HLA, who is not an identical twin of the patient, right? So there is never a perfect match. We only settled with close enough, making sure that there is no anaphylactic reaction that will occur. So once we verify that, so we proceed with immunosuppression. So we give them drugs that will tamper down their immune response. Usually, the drugs will target cytokines, specifically interleukins 1, 2, 6, and also tumor necrosis factor. So these are the major inflammatory cytokines involved in organ rejection. Meaning, unlike steroids, which pretty much inhibit the entire cytokine population of your body, these drugs will be more specific. That way we have, because we need the immune system too, right? We don't want to suppress it entirely. So we will just, instead of killing your white blood cells, we will just stop or inhibit the snitches, okay? Because the how your immune system works is, it's not always the white blood cells that get triggered. Something has to trigger the white blood cell production. Because look at your number, for instance. What's your normal white blood cell count?
5 to 10,000.
Okay, very good. 5 to 10,000. So something has to increase the production, right? Something has to trigger the release and maturation of new, specifically neutrophils, for instance. If you have a bacterial infection, something has to increase the production there, or increase the production of lymphocytes if we're talking about a viral pathogen. So something has to stimulate the production and maturation of these cells. And that something are called cytokines. So they're not technically going to kill the invader, but they will tell on the invader. Do you get the idea?
I get the idea. So,
Yeah.
so
So
once somebody has an acute or hyperacute reaction, are they always going to keep having that reaction every time? Or
with
is it just
acute, yeah, hyperacute, you saw the explanation. It happens one time because the organ is gone after it happens. You can't save it. You can cook it, but it's no good otherwise. In acute rejection, this happens again and again. It will never stop. You can only handle each episode at a time. So when it happens, you deal with it. And then that's it. And then next time it happens, deal with it again. Right? It's like catching a cold. Every time you get sick, yeah, you deal with it, you treat it. And then it'll come back again because there's no immunity against acute rejection. I mean, it's just a natural event, like I described earlier. Because this is a foreign object, of course, it will be targeted for elimination.
okay?
So this is the life of a donor recipient. So they will be taking immunosuppressants for life. That's why, if you remember in when we talked about TB last semester, were they at risk? Did they have did they fall under the 5 millimeter group for positive test for TB?
Yes.
Yes, they were under the high risk category. So this is a natural consequence. You want a organ transplant, you got it, but you have to accept the consequences with it. Because if you expect to keep that graft, then you'll have to take immunosuppressants. That's the only way. Because otherwise, you don't take it, then this will happen. You have acute rejection, that graft is gone, killed by your own body. Any other question? All right, so let's go back to your textbook. Let's go now to the drug therapy. So the drugs used, we will use for the purposes of the exam because I didn't go into signs and symptoms, right? If you notice, I didn't go specific into signs and symptoms of organ rejection because they vary, of course. It will depend on what did you transplant. So whichever graft was transplanted, the signs and symptoms will be specific to that organ. It's basically signs and symptoms of failure of that organ. For instance, if it's a kidney that's being transplanted and it is being rejected, what do you think would be the signs and symptoms?
Oliguria, maybe.
Okay, very good. So signs and symptoms of failure of the kidney. All right. So if we're talking about the liver, then what do you think the signs and symptoms will be? If a
The liver.
transplanted liver is being rejected or being killed
Signs and symptoms of the liver.
of liver failure. Very good. As simple as that. So let's describe a kidney. So here are your diseased kidneys. So let's say this patient had long-term diabetes, uncontrolled hypertension, whatever the cause is that led to both kidneys failing. So now they're gone, useless, not working anymore. They're usually left alone. I mean, they're alive, they're just not functional. So it's more trouble if you take them out because they'll be very bloody. Look at the size of these vessels here. Large artery here. This is your aorta, and that's the size of your renal arteries. So you're better off leaving them alone, right? They're not functioning, but they're not causing any problems either. They're not technically dead. No, they're alive, just not functioning. The nephrons are no good. So here's where you put the graft. So they'll use, instead of messing with the renal arteries and veins, they'll use the iliac right here. They'll put the renal and renal artery and vein of the graft. They'll put it into the iliac, not the aorta. So the iliac are way smaller, so they'll use that, and then they'll attach the ureter here, and then voila, you have a kidney. So as described earlier, here are your 3 common types of rejection. So here, even if you do immunosuppressive therapy, they will happen. So hyperacute, don't worry too much about this because this is again very rare. Like not even 1 in a million, even rarer than that. Or probably because it's not like we're doing a million transplants a month. Okay, it's extremely rare. Also, you'll have a few hundred. And acute again, first few weeks to first 3 months, and specifically for the kidney, here are again, they are nothing exclusive to rejection. They're pretty much signs and symptoms of the kidney failing. However, the onset is very fast. And then chronic, again, the onset is so slow, and these are your signs and symptoms. So azotemia is accumulation of BUN creatinine waste, and then proteinuria, leaking of protein into the urine, and high blood pressure. These though occur so slowly, so by the time we notice it, we can't stop the process. Again, can we delay it though? Hello?
Yes, you can delay it.
Yes, so once the doctor notices these, they'll put them on new or maybe higher doses of the immunosuppressants, which we'll talk about shortly. But again, the purpose here is only to delay it. At least we're extending the life of the graft, but there's no way we can stop it. Because we are using long-term corticosteroids here, I mean, we just finished adrenal problems. You understand that people taking steroids for life, or in addition to steroids, you're also taking anti-interleukins. You already know that these will be the consequences, right? So if they're put on steroids, these will be the side effects, not to mention the risk for infection. So here are your signs and symptoms. This is also related to the immunosuppressive treatment. Here, post-transplant, and here are your interventions. So very similar to what we did for CKD last semester. Same exact treatment, but focus on specific to the preventing rejection, of course, is going to be specific to the drugs. And here are your treatments. Well, this one here is about the kidney. So let's go here, post-transplant. So for treatment after transplant, these are your teachings. So avoid getting sick, avoid these people, wear a mask when you're in a crowd, or you really should be avoiding crowds, but if you can't, then wear a mask. The drugs, we passed it. No, it's not here. It's in a different page. Hold on. Drug therapy is in 375, I think. Yes, okay. So go to page 375. Not my fault. This is where they put them. They didn't put it together with the transplant. Put it under cancer. Here are the common drugs. Cyclosporin and mycophenolate are common, although these are not exclusive. You'll see cyclosporin in cancer. You'll see azathioprine or Imuran also in multiple sclerosis. We did MS last semester, right? Or no? Not yet, right? Yeah,
Multiple
I think we're doing
sclerosis.
MS this semester. So here are all autoimmune disorders. Look at that. And then definitely it's useful for organ transplant rejection. Mycophenolate the same, and then the same for azathioprine. So the patient may be on multiple. They may be both on two of these, or maybe these. Doctor makes a choice. So if you look at the action, they're not really unlike steroids, wherein steroids inhibit all of them, meaning they broadly inhibit all kinds of cytokines. So that's why you have more side effects if you're doing steroids. These guys here are specific. This one blocks only the helper T cells development. In order to do that, that means it has to block interleukins, therefore. So interleukins 1, 2, and 6 are responsible for stimulating helper T cells. So if you block those guys, then this will result. Helper T cells will not be developed. And then this one, same. So you will still target interleukins 1, 2, 6, and something called tumor necrosis factor. Tumor necrosis factor is another cytokine responsible mainly for rheumatoid arthritis and psoriasis as well. That's why if you take those drugs that suppress tumor necrosis factor, like you've heard of Enbrel, right? Commercial on TV, Enbrel or um, Humira.
Humira.
Yeah, Humira. Yeah, Humira is a tumor necrosis factor inhibitor. So it's very useful in psoriasis, in psoriatic arthritis, rheumatoid arthritis. So they're very effective um, against those because their response, the TNF, the tumor necrosis factor, is the responsible cytokine for the scaling of the skin, the destruction of your joints. Okay, so if you suppress them, then no more symptoms. However, since that's not their job is also this. All right, so that's why the consequence is still immunosuppression, making you susceptible to infections. That's why you see the commercials, as usual. Before starting Enbrel or before starting Humira, tell your doctor if you've had TB or are prone to TB, right? Because your immune system will be suppressed so low that you are now prone to getting TB. Right? Any questions?
Would necessarily a history of organ transplant be the reason to avoid, say, nephrotoxic drugs with nephrotoxicity or hepatic?
If if the organ involved is the kidney, yeah. All right. Here are your teachings and your actions. So all patients who are taking immunosuppressants after solid organ transplant or after bone marrow transplant are the following. These are your actions. Remember that they have a decreased immune response, meaning, do you wait for a high fever before you consider it an infection?
No, I won't.
No.
No, the
In
other
fact,
signs and
these
symptoms that
yeah, these people cannot have a high enough fever. So a low grade fever like 100.1 for instance or 100 Fahrenheit is already suspicious for infection because the immune response is so low that they're unable to raise their temperature as high as they used to. And these are again your teachings: avoid crowds. I said that. Do not change cat litter boxes. Right? Don't keep reptiles. They carry salmonella. Um, low bacteria, meaning nothing uncooked. So no raw steaks. All should be well done, well cooked. For fish, eggs, and no salads. Definitely no cheeses. What else? What else do we eat that's uncooked? Sushi. What else? Yeah, fresh vegetables. Anything you pretty much avoid Subway restaurants, right? Or the salad bar. No, no good there. Vegetables must be cooked. Okay. And here are again common sources of infection: a UTI, a upper respiratory infection, and here even 100-degree temperature is already reportable. All right, and then any drainage from a wound, say it's a needle stick, whatever wound they have. So make sure you monitor these. They are again very prone to infection for as long as they are taking the immunosuppressants, which is pretty much throughout the duration of the graft. Any question?
If they get the organ from identical twin, do they expect a similar treatment long term to prevent?
Organ rejection is less likely to occur, but there has been cases that yes, it can still occur. However, it's rare. I mean, it's an identical twin, so you're exactly the same. You came from the same egg, so you're pretty much the same person.
What about with siblings?
Siblings, no, not guaranteed. There may be you. There's a possibility you have a match, but by match, I'm not saying the HLA match, but I'm saying match as in good enough, but not very. It's not a given, right?
Okay.
Let's say I had a cousin, um, who needed a kidney because he'd been on dialysis for forever. He tested all his siblings because there were like 9 of them or maybe 8 from my mother's side. They all tested his siblings and none of them are good enough match. I mean, there are different organ transplant networks here in the US. I mean, we have a large enough database. The problem is the matching. However, they have what's called a donor network, meaning, let's say I need an organ, right? I need a kidney, and my wife is willing to give me her kidney, but we're not matched. So my wife will offer up her kidney to the donor registry and say, here, I have my kidney. Here's my blood test, So find a match for me, and I'm willing to give that. And then in turn, you have to find a match for Roger. You understand?
Okay. Like a
Yeah, they
domino.
have something like that. I mean, it's called a donor exchange, organ exchange. And it's not, I mean, completely, acceptable. It's not unethical. You're donating pretty much in the name of your significant other, your loved one, and then you're willing to give this to anyone who's also willing to give an organ to you. Didn't you see that? It was featured on CNN. They performed um, a transplant in 2 different states. They were not in the same state. So what they did was there were 3. It was in 3 states because the donors were not uh, matched to their family member. So what they did was they organized it. Okay, one, let's say in Seattle and then New York and Chicago. All right. So they performed the surgeries and then they had 3 helicopters fly the organs to the state. Okay, so within minutes they got the organ there. So they performed 3 transplants in one day. It was very, I teared up watching it, because it was because usually they don't tell who got it, but this one they knew exactly who was getting what. It was a nice story. You know, three different families involved, and they were just donating in the name of another. It was very nice. All right, any questions on transplant? Okay, none. Very good. Let's go to this lupus. Oh no, sorry. I still have medications here. Oh, okay, I remember. All right, the same drugs you saw there because it was only the indication and their action. So here are the specific never mind, they didn't list it. Okay, never mind. All right, here's the continuation for bone marrow. Just this section here, okay? Just this one. Okay, so we did the harvesting and then we did the pre and post procedure for that, right? So here is the entire bone marrow transplantation procedure. So I mentioned earlier that before we do the transplant, we have to treat the patient first, meaning the patient's bone marrow is cancerous. So therefore, it doesn't make sense putting healthy marrow in there because it will just be overrun by the cancerous stem cells. So what we'll do is wipe them all out first. Now that doesn't sound as simple as it's not as simple as it sounds because this involves major doses of chemotherapy and radiation, meaning we will have to almost kill the patient. That's not the intention, but that's what's going to happen because when we give high dose radiation and chemo, this will wipe out the entire bone marrow of the patient, meaning they have no ability to grow new marrow. And this is now the perfect state of the patient. That way now we can put another person's marrow in there, which will now grow cancer-free. Any question on that? But before we can do that though, again, the most dangerous part is after the treatment. Does that make sense? Meaning when you do this high dose therapy here, this one, followed by the infusion, this is the dangerous part because if this patient gets an infection, are they capable of defending themselves?
No, you're not.
Absolutely not. Yeah, they are completely defenseless. So it's not a simple procedure. This patient must be in a controlled environment, a private room, strict transmission-based precautions, strict universal precautions. This patient is a very immunocompromised patient, so protect them until you can put the new bone marrow in there. So here, the stem cell transplant rescues the patient, meaning you already eradicated the patient's marrow because it contained cancer. So you kill the entire marrow and then you put in a brand new marrow in there, which will now grow new healthy blood cells. So you have no more leukemia and you're cured. A possible problem here is we just talked about organ rejection. So in organ rejection, whether it's hyperacute, acute, or chronic rejection, who attacked who in organ rejection? Guys?
Your body's attacking.
Okay, so is it the host or the graft? Who attacked who? The host attacked what, or the graft attacked what? What happened in organ rejection?
The host is attacking the graft.
Okay, very good. So that's what happened in organ rejection. However, in bone marrow transplant, something opposite could happen. Because again, I described to you that we pretty much wiped out the entire bone marrow. So is the patient capable of defending themselves before the transplant?
No.
Absolutely not. They have zero defense. Now, if we make a mistake wherein the marrow that we transplant contains viable white blood cells, meaning they contain active white blood cells, what do you think will happen? Is the host capable of attacking the graft?
Yes, it will. Try.
We wiped out the entire bone marrow. So is the host capable of attacking the graft?
Oh no.
No.
No, because you have wiped out only
Absolutely
bad,
not. However, right. However, if the graft bone marrow contains viable active white blood cells, what will happen?
it will now try to defend
It
itself
will be the
against the
opposite.
host.
This time, the
Yeah.
graft will attack the host.
Host. Yeah.
Okay, so that's what we call graft versus host disease. So it has its own complication. The patient can die here, okay, if we make a mistake. So
Yeah.
before we transfer
Isn't there
that
a
marrow,
possibility of rejection, Professor?
again, we don't call it rejection because in organ rejection, the host attacked the graft. Here, that doesn't happen. The host here is incapable of attacking because it was wiped out. The bone marrow was wiped out by chemotherapy and radiation. So the opposite could occur. So if this marrow that we are transplanting here, this marrow that is intended to rescue the patient, if this marrow contains viable active white blood cells, this host is in trouble because now this graft will attack and kill this patient. Does that make sense?
Yeah.
All right. Any question? Let me just check if okay, yeah, that's it. Okay, let's move on. We still have 20 minutes left. Let's do 243.54. All right, let's do lupus, and this should be it. We'll continue with Guillain-Barré next week. All right, lupus. This is a systemic connective tissue disorder. It's genetic. It's autoimmune. No, sorry, it's not genetic. It's not passed on from one person to another. It's autoimmune. You just develop it. You acquire it. It will affect all connective tissues of the body. Here are some of your risk factors. North or South America, Europeans, Asians, so it doesn't really pick any. African American women, 4 times more likely than Caucasians. However, overall, it's not very common in Africa, Asians, or African Caribbeans. Hispanics, higher prevalence compared to Europeans. As far as gender, I think it's more, more females than males. Again, it's autoimmune, nothing we can do to prevent, or definitely no treatment, no cure. No cure, you can treat it. Okay, it can be managed. Again, I'd like to emphasize that this is autoimmune and it will affect all connective tissues. Now, imagine connective tissues. Where do we find connective tissues in your body?
Everywhere.
Everywhere. There's no body system that doesn't have connective tissue. Otherwise, we will fall apart. So, connective tissues are tissues that hold our body together. Examples, your skin, the entire skin, the largest organ of the body, is connective tissue. Blood is connective tissue. Our blood vessels have connective tissue. Every organ of the body, the lungs, the kidneys, they have connective tissue. Because again, without connective tissue, it will fall apart. It can't stay together. Our joints are connective tissue. We have tendons. Muscles have connective tissue. Fascia is the connective tissue covering the muscle. Then we have the joints, etc. Kidneys have connective tissue. As far as what will flare it up, because we're talking about an autoimmune chronic disease here, so you have it for life, you have to live with it. However, you don't have to be sick with it, meaning having symptoms all the time. It does have periods of exacerbation. It also has periods of remission. So our goal, therefore, is to extend the period of remission. We want this patient to be as symptom-free for as long as possible. So that is our main goal. We have to know the triggers. So what are triggers? When we say triggers, these are factors or events that will cause an exacerbation, meaning will cause your symptoms to flare up. Unfortunately, they fall under one vague, broad category, which is stress. Now, what is stress to you? Is it the same for all of you? Is stress the same? No. Each one of us have different sources of stress. We consider something stressful, which some of you, another person may not. Okay, common though are the following. Again, this we have more female patients here. So pregnancy definitely is stressful. And look at the age group. I forgot to mention that. What age group are affected here? 16 to 55. So what happens between at least 16 to 40? What's happening to these women? When you're right now, you're between 16 and 40. What are you? Yeah, you're in school, you're working. Are you childbearing age?
Yes. Yes.
Yeah, definitely. So if you're in the age group that could develop lupus, and look at again the rest of the triggers. Exposure to sunlight. So if you're someone who worships the sun, goes sunbathing, so you can't do that anymore. And that's a lot of trigger because your body's covered with skin, which is all connective tissue. Illness, so that could be the flu, a cold, whatever sickness you have. Excuse me. Surgery, silica dust, and medication allergies. Let's go to signs and symptoms. There's a lot because we're talking about connective tissues here. So we're covered with connective tissue. So here is a long list of your signs and symptoms. So when you have a flare-up, all of these will be inflamed. So table 19.8, let's start with general. You'll have overall fatigue. You'll be tired, you'll have a fever, difficulty concentration. Remember, your brain also has connective tissue. Mucocutaneous. So the skin is the largest organ and largest connective tissue also. So therefore, the skin will be affected. There will be a rash, not only on the face, because the classic manifestation is a butterfly rash. This is across the cheeks, meaning you imagine a butterfly, right? The wings of the butterfly will be on your cheeks, and then the body of the butterfly will be your nose. So the rash will be there from the bridge of your nose all the way to your cheeks, forming a butterfly. They will also be discoid lesions. There are two types of lupus, by the way. We have discoid and systemic. We're talking about the systemic type here. In discoid lupus, it's much milder. It only affects the skin, but that's rare. Most cases are systemic. Definitely, there's photosensitivity. You lose hair and itching and um, rash everywhere else besides the butterfly rash. And you'll have ulcers in your mouth, in your nose, or even in your genital area. Musculoskeletal. Most common and frequent complaint is pain, joint pain, as well as abdominal pain. Abdominal pain is actually in renal involvement already. Abdominal, I mean the retroperitoneal area in the abdomen where your kidneys are. And you've heard about Selena Gomez, right? She has lupus.
Yes.
She lost her kidneys, right?
Yes. She
So
also had a kidney transfer. Yeah.
right, yeah. So these are one group of people who will require a kidney transplant. So frequent attacked organ in lupus is the kidneys. This is usually why they get hospitalized, not for the muscle pain or these rashes here or the fatigue. It's really kidney involvement. They're hospitalized because they're having kidney failure already. Neuro, I mentioned, so look at the signs and symptoms. You could develop a stroke. Look at the heart. The heart has a sac, a connective tissue called the pericardium, right? The lungs also have the pleura, causing pleurisy or even pleural effusion, and even pneumonitis. Eyes, you have retinal lesions, and then for blood, you'll have pancytopenia because the bone marrow is connective tissue as well. So you have anemia, neutropenia or leukopenia, and then thrombocytopenia. All blood cells are low. So is it fun having lupus?
Nope.
All right. Now, don't get me wrong, okay? As far as the pregnancy here being a trigger, right here, um, yes, they can have an exacerbation or flare up, but the the evidence really is, let's say the pregnancy triggered it, right? Should the patient choose to terminate pregnancy, the risk of an exacerbation doesn't really change. Meaning the fact that you got pregnant, whether or not you carry the pregnancy to term, or if you choose to terminate the pregnancy, it doesn't matter because it already is triggered. Does that make sense?
Yes.
Meaning having an abortion won't stop the flare up. Does that make sense?
Yes.
Yeah.
Yeah.
So meaning, you got pregnant, it's too late. You already got, it's going to cause a
Got
flare up,
pregnant. Yeah.
right? But whether or not you have an abortion, it's likely though, especially if you have kidney involvement. So you may have a possibility of miscarriage. But I know a lot of people with lupus with 3, 4 kids. I mean, they did it fine. You just need to um, oh, I'm not testing this table, by the way. This is already for diagnosing, so we're not doctor. We're not doing that. What was I saying?
That many people
We were
with
talking about the
several kids.
pregnancy.
Oh, yeah. They just need to time it correctly because we know that sun exposure triggers a flare up, right? So when do you have less sun?
Nighttime.
In the winter.
Okay, no, I mean season. Yeah, right. So I'm referring to fall and winter. So the best time to get pregnant is in the fall and winter. That way you give birth by what? By spring, right? So if you get pregnant around this time, September, October, which is not very hot anymore. So that you got what? September, or so you give birth around May, right? So May is starting to get hot, so that way you avoid the hot summer months. So that would be the best time to conceive with less possibility of flare-ups because pregnancy is already a trigger in itself. So you don't want any more heat or sun exposure to add to the trigger. All right, testing. It's not easy to diagnose lupus. Typically, because there's no one test to diagnose it, the doctor has just had to make sense of all these tests here. So because it's not exclusive, let's say for instance, nuclear antibody, this ANA, is not here in itself, does not confirm diagnosis because 2% are positive, plus ANA is not exclusively found in lupus. You also see it in rheumatoid arthritis, in systemic sclerosis, in psoriasis. So there are different autoimmune disorders that have a positive ANA. Multiple sclerosis has a positive ANA test. So no one test will confirm it. It's more like they'll do all these tests to rule out other causes. That way the doctor can make sense. All of these checked out fine. This is pointing to lupus, right? Treatment. Okay, so this is now, let's start with non-pharmacologic first. So again, the number one trigger is sun exposure. We can't avoid the sun. I mean, what are you gonna do? Live in a bunker? So now when you are outside, try to use an umbrella, a large brim hat, or if you can't avoid the sun altogether, make sure you wear sunscreen, has to be SPF 50 or higher. Diet would be good. Remember, the patient has fatigue, so rest, exercise. I'm not testing this one. Table 19, not 10, you can disregard that. Again, that's I don't think that's a nursing thing. Okay, drug therapy now. Because you're the ones teaching these patients about these. Remember the famous hydroxychloroquine?
Yeah.
All right. So this one's not for COVID, all right? So this is an anti-malarial medication used for lupus. Now, how the drug works is it prevents the skin from absorbing ultraviolet rays. So therefore, does it help prevent an exacerbation when the sun hits your skin?
Yes.
Yes, that's the reason why we take hydroxychloroquine for lupus. So helps prevent flares and organ damage. So it's pretty useful in lupus. Again, um, as already widely known because of Trump, it does cause some cardiac problems. Here are some mild but still inconvenient side effects: abdominal pain, nausea. And because you're not just taking this, but you're also taking it is an autoimmune disease. So we're still talking about the same immunosuppressants already taken, for example, azathioprine or Imiran, which was used in organ rejection, is also used for lupus. Steroids usually are used if the patient has an exacerbation. So if they're admitted for a flare-up, they'll be put on large dose steroids. For pain, for joint pain, abdominal pain, because it's inflammatory in nature, because it's a connective tissue being inflamed. So NSAIDs will be very important for that. Now, since these patients will be taking NSAIDs regularly because of the pain, what should be added here? We just finished peptic ulcer disease. What will you add?
An antacid or something to coat the stomach.
What was that drug again? Used to
Sucrate, I think it was. Or is it?
Terrific.
letter M.
Not
My
MAOI.
no, my Lexa or something.
No, starts with an M. Sounds like a Japanese soup. Misoprostol.
Yes. Yes.
Okay, all right. So don't forget, okay, these are all related. Remember, these go round and round. Here's a, I really don't like to talk about this because biologic response modifiers, these are very expensive. But let's say the patient has good insurance, so they can afford this. Belimumab. Again, this is not meant to cure, all right? So monoclonal antibodies will just here is for lupus specifically, this will decrease the immune response causing the manifestation. So again, this is autoimmune, there's no cure, you can just treat it. All right, here are now your summary of your drugs. So 19 table 19.11, this is definitely testable. So you've got your NSAIDs, steroids. Again, the high dose steroids usually is given during a flare-up. If you have an exacerbation wherein these are present, then you'll be given high dose steroids. But for day-to-day symptom management, you'll be put on low dose steroids, maybe 5 milligrams prednisone daily. We have topical for the skin rash, especially for the face. Patients are also allowed to put cosmetics as long as the makeup has a moisturizer, because we don't want the skin to dry, so you can hide the rash. Because again, you're between 16 and 55, so if you're still single and you have that rash, you may end up staying single for a while. All right, so you are allowed to cover it up. Use makeup, again with makeup with moisturizers. And here are your immunosuppressive agent. Okay, so same thing, we already did it was cyclosporin. This time it's cyclophosphamide. But mycophenolate is there. Mycophenolate was Cellcept, yeah, that was used in organ rejection. And methotrexate, if you remember arthritis last semester.
Mm-hmm.
Yeah, and then azathioprine, also mentioned in organ rejection. And when did you do thalidomide?
The baby. We're talking about last semester when we we're talking about things that can hurt fetuses or tetragenic medications.
Yeah. What was this used for? To treat?
Anti-nausea.
No, this was in hyperthyroidism, remember? But you're right, it is teratogenic. This was used in, remember PTU and methimazole?
Yeah.
Yeah, methimazole and PTU were thalidomides. And here's the expensive BRM. Complications. I already mentioned kidney failure, and then you'll need a kidney transplant. But on top of that, here are your other problems. Besides renal failure, you have the heart disease, the lung disease, stroke because of the hypercoagulation, and of course, because of the treatment and the disease itself, you are at risk for infection. Surgical management usually is the organ transplant. You need a renal transplant, which is commonly done in lupus patients. Here's a alert for hydroxychloroquine and NSAIDs. And we already discussed the misoprostol. And here is a summary of your nursing interventions. And that's it for today. Any questions before we go?